Good afternoon. Thank you for the invitation to present, in my opinion, a very interesting topic, the topic of the future of the nuclear medicine and radioisotope therapy. To begin with, before I address the key topic, I would like to remind to you what radioisotope therapy is, targeted therapy in particular. So this therapy takes place when intentionally we administer therapeutic dose of radiopharmaceutical to the patient's body. Targeted means personalized, individualized therapy. So we do not administer radiopharmaceutical to every patient who has some indications. We have to check whether this specific individual patient will provide a good response to our therapy. For instance, that he or she has sufficient number of receptors for the radiopharmaceutical that should impact cancer cells. Radioisotope therapy can be provided intravenously. It can be also oral administration, or radiopharmaceutical can be injected directly into the tumor or the space after the tumor. This kind of therapy has a lot of advantages. First of all, we can monitor the uptake of radiopharmaceutical directly after the in vivo administration, so inside the patient's body. So we can use SPECT or PET techniques that initially, just after the administration of the drug, we can see the location of the radiopharmaceutical. We can trace its path throughout the treatment process. So we here take the theranostics approach. So the therapeutic radiopharmaceutical, or the ligand included in the radiopharmaceutical, can be combined with radioisotope that provides us with diagnostic signals. So the qualifications of the patients is very precise when we consider the treatment, and we can also deliver very effective therapy based on this qualification. So this is the theranostics-based approach, and this is the idea of the targeted radioisotope therapy. Another advantage of the use of this therapy is the fact that the radiopharmaceutical is to join these areas that allow it to be joined. So it joins a specific receptor. But if such groups of receptors are not present in healthy tissues, the radiopharmaceutical cannot be joined. So there are lots of post-therapeutic consequences when the healthy tissue is damaged, or we can also generate the appearance of new tumors. Another advantage I would like to stress: now we can select isotopes due to their physical properties, and we can select the specific items that will be optimum for the patient. So here the examples as the use of erythrolytate, which are used for isotope therapies. Nuclear medicine, as of today, offers many effective radioisotope therapies, starting with the historical ones, such as the use of iode to treat different thyroid cancers, or palliative treatment of patients with bone cancer, or to treat patients who have non-surgical endocrinic tumors. So there are lots of therapies we can offer. All the time they are developed, and we are searching for new groups of patients we can help. One of the paths of development we can study is the replacement beta minus emitters, that is the isotopes that emit electrons, alpha emitters. So this is a very interesting option. It's a new option that is becoming popular in nuclear medicine, so it's worth studying. So we have to explain why alpha emitters have good future in nuclear medicine. But to decide this, we can look at the alpha and beta minus molecules, their physical properties, and how it translates into the application of radioisotope therapy. Alpha molecules are 2 protons and 2 electrons that create a nucleus. Beta minus is just an electron. Both these particles are different when it comes to their weight. Alpha particle is 7,000 times more than a single electron. The initial kinetic energy is also different when they develop, and in alpha particles from 3 to 8 mega electron volts. It's a very high kinetic energy this energy can be left in the material of the tissues of the patient. These particles, when it comes to their physical properties, they also differ by the range in tissue. Alpha particles, this range is very small. They travel in the patient materials from the place of emission to several micrometers. Electrons are characterized by the greatest range in the soft tissue to about 1 centimeter. So it translates into a key parameter for all the therapies which use the ionizing radiation. So it's the linear transfer of energy of alpha. This linear potential is huge. It's much greater than lead, that in lead electrons. I will later show you the differences in these 2 types of material. So it's all translated into the number of hits on the cancer cell to stop its multiplication. So 1 to 5 for alpha particles is enough to prevent multiplication of a cancer cell. In the case of electrons, you need to have a lot of them to achieve the same therapeutic effect. So the difference is like the difference between the size of elephant and mouse. So this is a comparison between alpha and beta particles and their effects. I have managed a very high lead. It's between 50 and 200. So there are also other forms, other beams used in radiotherapy. Alpha particles are characterized by the highest LET from all the therapeutic options that can be proposed to our patients. LET is important because the high LET results in the situation that the radiotherapy will be efficient also for hypoxic tumors, regardless of the cycles of the cancer cells. That means that it's a very attractive option to the patients that before were immune to oncological therapies with beta particles, but also it will be good for patients who were immune to radiotherapies with the use of other beams, but it's conditioned by the fact that we will find the appropriate ligand. So alpha particles or radioisotopes that emit alpha particles, they have become a very well-researched topic in radio isotopic therapy and in nuclear medicine. Here I'm showing to you the isotopes with the highest potential. So radium 223, it was the first radioisotope that has been registered for the use in the clinic. There's bismuth, astat, and the therp. All of them are characterized by the fact that it's very easy to combine them, to join them with the particles that facilitate joining of the radioisotope with ligand. This is very important in the nuclear medicine. If we cannot provide a stable radioisotope with the specific ligand using the specific chelate, then the effective therapies would not be possible. So quite a lot of these radioisotopes that emit alpha particles creates stable compounds, bindings with ligands. Here there are some examples of benefits to the patients when we use the targeted radiotherapy with alpha particles. The first one here, we use the radium chloride application. So this patient has received quite a lot of benefits due to this therapy. This is also a paper, I'm presenting a paper that registered this preparation in North America and in Europe. And at present, this is the only registered radiopharmaceutical which emits alpha particles. The next example, actinium-225, is used in a patient with a tumor from pancreas. The effect is impressive because this patient has already undergone many therapies that were ineffective. So the line of treatment used lutetium and somatostatin factors, agents, but there was a decision that he or she should receive actinium-225 labeled somatostatin receptor agonists and antagonist. This is another example of the use of lead-212, a very interesting clinical essay on the use of terbium. So these are clinical studies, but radium chloride is the only registered agent, and we can use it for our patients. The remaining agents are used for the clinical trials or even pre-clinical trials. I would also like to mention a very interesting Polish contribution. This is the Medical University of Warsaw, and for the past decade the university has researched bismuth to treat patients with recurring gliomas. So the group of Professor Królicki received a very important European award of Marie Curie Skłodowska, which is awarded to the best work in the field of nuclear medicine and radiology. So we're very proud that such studies have been delivered in Poland, and this therapy is available for our patients. Careful observers have probably noticed that so far I have not mentioned any information that would indicate the documentation of the distribution of radiopharmaceuticals, which include radioisotope emitting alpha particles. All the images you've seen so far, they were the PET-CT images that documented the condition of the patient before or after therapy, but no images were presented, images on the course of the therapy. So I will start the key part of my presentation now. And this is just like, just to cheer us all. I wanted to show you the path of the alpha emitter. So first this B is quite confused, then actually there is nothing to image, so this B is laughing. Then there is this anger because the process was very hard. We didn't know how to start, what to start with. But then you have to pull yourself together and you have to face the challenge. And it also has to be the teamwork. So you need many scientists to work together to manage to address this challenge. And what the future will be like, we will find out. So let's start the journey through showing you the alpha emitters. So what should we image? Here, again, I'm showing to you these alpha emitters I have already covered with the highest potential to be used in the clinical studies. So it's not only about STEM isotopes, but it's the isotopes that emit alpha particles, and they have a lot of daughters that are included in the chain of decay. So we have to consider what we are going to image. So what can we image? What are we able to image? There is a chance there are radioisotopes that decay and that include gamma emissions. So bismuth is an example of this isotope. So there is gamma radiation, which reaches the level of 440 keV. So we could consider bismuth. Another example is actinium-225. So there is no gamma line here, but when there is the decay chain, which includes some daughters that are accompanied by the gamma lines. And so here we can use bismuth 213, France 220Y, actinium 225. So in the case of isotopes that have no additional lines we could concentrate on, we could try to image their distribution using surrogates, isotopes that pretend kinetics of the isotope in the patient's body, and we could use it to recreate the distribution of the isotope. But it's the last resort. If we have nothing else to use, we can follow this line. If we are able to imagine some gamma line radiation, we should also address additional difficulties. First of all, the activity that is administered to the patients when we conduct alpha particle therapies. So this activity is very low. It's just a few megabecquerels. In the case of classical radioisotopic therapies with lutet or yttrium, the activity administered reaches individual gigabecquerels. So not this very small gamma radiation that could be imagined is produced. There's also very limited total number of counts in the image with a significant proportion of noise. So we have issues to adapt to select the specific collimator. There are problems with the partitions of the collimator. So we have a very limited number of counts available to reconstruct the image, and many of the counts is just the noise. Here you can see an example image of a patient who received actinium-225. As you can see, this is the image of poor quality. There is a low relation between signal and noise. A lot of noises are produced here. It's hard to select the right energy window. In the case of energy spectrum of actinium, we can see 3 peaks we can use, so it's very hard to select the optimum conditions of the imaging process to make sure that there is a good quality of the image, to be able to use the image for the purpose of quantification. So, what have we managed to do so far when it comes to the qualitative or quantitative imaging of alpha emitters? The first example here is the paper for radium-223. This is the only alpha emitter registered in Poland. So in our clinic, we delivered some studies at the pre-registration phase of this preparation, and it considered the possibilities of quantitative imaging to make sure that we will be able to calculate the absorbed dose after administration of this radiopharmaceutical. As you can see, these were only the planar images. At the time, spectral imaging was not available, so satisfactory results were accomplished when it comes to the quality of the image. So appropriate quantification could be carried out, the absorbed dose could be calculated. The studies were continued by several authors several years after the registration of 223 radium. Currently, the situation is that it has been summed up that quantitative imaging is possible after the administration of radium, but it's very difficult and it's time consuming. So it hasn't been implemented in the clinical practice. So we know that we are able to do it, that it is possible. However, we do not use this imaging for all the patients who are treated with radium-223, and we do not provide dosimetry, coordinated dosimetry for such patients. When it comes to the imaging with bismuth and actinium, this is a STEM, actinium is STEM agent for bismuth. So this is a publication published in 1999. It's the first paper published by American scientists, very experienced scientists in the field of dosimetry of radioisotopes administered systemically. So the first images were published, and they were used for the purpose of quantification to calculate absorbed dose after the administration of this agent. When it comes to the regional administration to the tumor, the first paper was published in 2010, and these are some exemplary images. Actinium, I found some information, some mentions in the paper of 2016 on my right-hand side. So it contained the information that such images were registered. However, the paper does not present the images. So I'm just showing these images that were presented by the authors. However, we can read that the images after the administration of actinium were registered for this group of patients. In other papers, there's the mention on the images registered for the patients, and again the bismuth lines again were used, and such images were published in the early 2020s. So they are very hard to interpret. There's very low quality. And these papers did not refer to the quantification of such images. The authors only just mentioned that it's possible for registration to analyze it in terms of their quality.
Let me also mention that Professor Kulnikowska and Professor Królicki team from University of Warsaw has some impact on quantification of SPECT images for actinium-225, and this is our paper that we published this year regarding this topic. And we tried to prove the thesis that it is possible to use more than one energy window simultaneously in order to activate such an image. So those who are interested in this topic, feel free to get access to this paper. So when we speak about quantitative issues for images with the use of actinium, there are very few images to be studied and to try to assess the quantification values. Actually, there are really few cases, few images of this type. This is a new, very difficult field of research right now, and we are waiting for new papers on this topic that would show us how to proceed properly and that will document this practice in a proper way and show us how to quantify the dose when applying this type of isotopes. As regards other radioisotopes with alpha particles, most of them are being now at the testing phase, not even clinical testing phase, but pre-clinical testing phase. I have managed to find one paper, but as you can see, the quality of the images is very poor, and well, the confirmation of the possibility of quantitative imaging for these types of isotopes, we have only phantom-based tests, Monte Carlo simulations, or as I said, preclinical model tests, mainly performed on mice. So it will take some time until we will get a chance to have images of our patients. So these were that was experience of individual centers that published their results, research results, but the society, the community of nuclear medicine find alpha emitters as their future. Therefore, they have taken concerted effort to make sure that alpha emitters can be included in quantitative imaging and dosimetry. So here you can see European project called AlphaMed, and different centers of nuclear medicines, but also other institutes participated in the project, aiming at developing proper protocols to resemble the activities of radioisotopes, including alpha emitters, so that we can quantify everything properly. So there is a hope for us, and there is hope that we will manage to struggle with this very difficult topic. To sum up, is quantitative or qualitative imaging of alpha emitters possible? Yes, it is feasible. Is it problematic? Yes, it is definitely problematic and very, very difficult. This is a very complex topic, and it is really hard to find out how to start examining it and proceeding with it. And the research field, will it be used routine? Well, for a long time it will not be applied clinically for sure, because proper quantitative and qualitative imaging still requires a lot of work, requires a lot of studies. But definitely, this is a proper field of research. Definitely, we need to put a lot of effort in examining this field, and we hope there will be a lot of papers published to all of us. Thank you very much for your attention.